Welcome to the APAPP podcast. I am Corinne Young. I am the current president and founder of the Association of Pulmonary Advanced Practice Providers. We do have a new president coming in later this year, so definitely stay tuned. She'll definitely be on the podcast as well. Today, we are talking about bronchiectasis, and joining me today is Jennifer Faber-Gerling. She is a nurse practitioner at National Jewish. You may recognize her from a previous podcast that she did on mycobacteria, on avium complex. She is pretty much an expert, I would say, in the area of mycobacterial diseases and bronchiectasis. So thank you so much, Jennifer, for joining us today.
Corinne, thank you for that nice introduction. I'm really happy to be talking about bronchiectasis, as it seems to really be in the forefront of all of pulmonary care at this time. And in talking about it, bronchiectasis is a chronic respiratory condition, and it's characterized by irreversible airway dilation and impaired mucociliary clearance. And despite its clinical significance, bronchiectasis remains really underrecognized, and it's often diagnosed later than ideal. And when we say later than ideal, what we're trying to prevent is progression of disease and irreversible damage to the airways. Our goal is to provide a clear overview of the pathophysiology, clinical presentation, and management of bronchiectasis today.
Yeah, I think you really hit it on the nose that it's often missed. It's chronic cough for a lot of patients. They're treated for all sorts of different things. They may not get the right diagnostics to get diagnosed. And so, unfortunately, a lot of patients do suffer with this for quite a while. Yeah. So if there was a definition of bronchiectasis, how would you define it for our listeners?
I think the best definition is it is characterized by a permanent abnormal dilation of the bronchi. And as a result, there is chronic inflammation and destruction of the bronchial wall. And, the way I present it to patients is that my general definition for you for bronchiectasis is airway inflammation or scarring. And we're trying to figure out why that's there.
And there's a lot of different types of bronchiectasis and how it might be described on imaging, right? So what are some of the terms that people might see if they send a patient for a CAT scan? What might they see back from the radiologist if they're not looking at the imaging themselves?
They may see, it depends on the radiologist. If you have a skilled thoracic radiologist, they're going to label it bronchiectasis, but you may see airway dilation, sometimes atelectasis. It could be described as different types like varicoid or cylindrical bronchiectasis. When you see it on a radiograph, like a high resolution CT, we call that signet sign. So typically an airway is adjacent to a blood vessel. And how we describe bronchiectasis is when that airway is larger than the adjacent blood vessel, that is bronchiectasis. Sometimes you capture the whole length of the airway and it looks like a channel, but sometimes you just get the end of the airway that is dilated and larger than that adjacent blood vessel. Still bronchiectasis.
Yeah, I love that definition and what to look for. And I highly encourage, I know I harp on it all the time, you all should be looking at your own imaging. Even if you don't know what you're looking at, just keep looking at it. And things are going to start popping out to you that you don't know what it is, but you know it's not normal. You have to get used to all the normals to identify the abnormals. But looking at those airways with the air, with the blood vessel next to it, the blood vessel should be larger than the airway. And if the airway is larger than the vessel, that's telling you that something's going on with the architecture of that airway that is abnormal. So when this damage happens to the airway, it's kind of losing its structural integrity. How does that impact the airway?
Well, it impacts the airway because most of our airways are lined with cilia, which are little hair follicles. We have them in other parts of our body as well. But those cilia, it's called ciliary bead, and it has a motion that actually cleanses that airway or is the housekeeper for that airway. And with that inflammation, which is bronchiectasis, it impairs those cilia's ability for mucociliary clearance. And it creates an environment then that's conducive to bacterial colonization and recurrent infections. And there is a model out there called the vicious vortex. And we sometimes joke that in a conference looking at bronchiectasis, how many times is somebody going to refer to that vicious vortex model? And it's a graphic representation of the cycle, and it shows the interconnection of the key components, which is airway clearance, airway inflammation, mucociliary clearance, and the structural lung damage that bronchiectasis causes. And if you're watching this on YouTube, you will be able to visualize that vicious vortex model.
Yeah, thank you for providing that. Now, when we look at why this happens, I know that vicious vortex does kind of lead us down some paths of the why behind the bronchiectasis happening. Can you describe that to those that aren't able to see the model?
Yeah, I mean, it actually is kind of a circular model with lots of arrows of showing the connection of those key components, that epithelial dysfunction, the mucus hypersecretion, the ciliary dysfunction, neutrophilic inflammation that's created, T cell infiltration into those airways, that can lead to immunodeficiencies, chronic infection and bacterial factors that can contribute to bronchiectasis, and then ultimately that lung destruction that can happen as a result.
So, what are the most common causes that we would see behind bronchiectasis?
When I'm talking to patients, that's the big question. And I think everyone that has evidence of bronchiectasis on a CT really should have a full bronchiectasis evaluation to determine if there's anything that predisposes that patient to that bronchiectasis. Some common things are recurrent infections or post-infectious. You may hear in a history that this patient endorsed severe childhood respiratory infections or had bronchitis, recurrent bronchitis, which may or may not have actually been the case. Also, tuberculosis is a common predisposition to bronchiectasis. Genetic predisposition, mainly cystic fibrosis, primary ciliary dyskinesia, and alpha 1 antitrypsin deficiency. Cystic fibrosis is also, I think, underappreciated in some of our older adults, right? It's not always looked at when they have recurrent infections. And I think, honestly, it's really easy to screen them with a sweat test initially and then potentially progress to genetic testing to determine if they're eligible for other things like disease modulating therapy, which could change the trajectory of their life. So I think that's really important. Immunodeficiencies, that may be a reason for those recurrent infections. Autoimmune disorders. And the way I discuss this with patients, I identify the three common ones, which is rheumatoid arthritis, lupus, and Sjogren's syndrome. But I also talk about, um, with these autoimmune disorders, it's where the body creates itself. It causes inflammation, and it causes inflammation of the lung. And it is could be the cause for the bronchiectasis. We call that autoimmune lung disease. So also very important to just rule it out and check the box and move forward. Unfortunately, despite extensive workups and evaluations, a lot of the times we're not able to understand the reason for that. And we use that term in medicine called idiopathic, and that still can be a predominant reason for people's bronchiectasis.
Yeah, sometimes you're hoping if you can identify the underlying cause, maybe you could do something about it. I do want to circle back to when you were talking about genetic causes. Is one thing I remember being taught at some point regarding alpha 1. We think about alpha 1 antitrypsin deficiency as more of a parenchymal disease affecting, causing emphysema in the air sacs. But we could have bronchiectasis with it as well, and cystic lung disease. And oftentimes it tends to be multifocal. Is that correct? It doesn't seem to be just like an isolated cystic area. Is that been your experience?
Honestly, I think about disease patterns of disease on radiographic, CT imaging. And there's a subset of things that cause lower lobe disease, and alpha 1 is one of those.
Mhm.
Immunodeficiencies also could present as lower lobe bronchiectasis. One genetic disorder, primary ciliary dyskinesia, can be lower lobe predominant as well. And you can't underappreciate, and I never just hang my hat on this, but the role of reflux and aspiration for bronchiectasis, because gravity takes those secretions where they want to go, which is the bottom back portions of the lungs as well. So, all of those factors can contribute to a cause for the bronchiectasis. I think about cystic fibrosis as being more diffuse, maybe more upper lobe predominant when you're looking at CAT scans, but I'm sometimes surprised about that. The pattern can be a little bit off as well. And we're not just looking at the radiographic imaging, these just may be cues for
Right,
people.
right. Now, as far as of the causes being post-infectious, genetic, autoimmune or immune dysfunction, or idiopathic, what would you say in your practice, since you see so many bronchiectasis patients a day, what would you say is the most common cause that you run into?
Actually, I see all of the above. And, there still is a predominant number of patients where it's just we don't know what the reason is, or it could be multiple things influencing it.
That's never
We've
fun
had
when it
people win the genetic lottery and they're heterozygotes, meaning they have one mutation and they don't really cure the diagnosis. But I have a hard time believing that does not impact their lung function in some way.
Mhm. Yeah. Okay, well, thank you for that. All right, so when should we be thinking I should work this patient up for bronchiectasis? What kind of patient are we going to be seeing that may have clinical presentations that make us curious to get imaging of their airways?
And that's a great question. And I think the reason why people take a long time to get to that point of diagnosis is that the symptoms that they present with are very vague. But one thing I would say, most of the patients endorse a chronic productive cough. And this isn't just weeks of this, this could be a year or two having this chronic productive cough, and they have no other symptom. That's not normal. And, it can impair their life. Since the pandemic, coughing in public is not very socially appreciated anymore. So this can be pretty life altering to them. And I hear over and over again from patients is that I keep telling my provider that this is happening and I'm coughing all the time and nobody has an answer for me. You got to listen to that. The other thing is a pattern of recurrent respiratory infections, and not just treating the symptoms. Why are they having those recurrent infections? Is investigating that. And, sometimes they'll have exertional dyspnea, although the way it's described in the presence of bronchiectasis is it's not like they're just talking and walking and they have shortness of breath. They describe when they go up inclines or stairs or stress themselves in that way, they're short of breath. But if you were to put a pulse oximeter on them at that time, they're not dropping their saturations. They just have this sensation, and it's more about the airway collapse than it is actually they're dropping their saturation. They recover very quickly, and they're really not hurting themselves. It's a reflection of the underlying bronchiectasis. Now, having said that, some people have comorbidities that may be contributing to that shortness of breath, and that's another situation.
I'm glad you said the airway collapse because I don't think we always think about that with bronchiectasis is that because the architecture is lost, it can't prop itself open. Although it looks dilated on imaging with exertion and dynamic, airway function, they do collapse. And so that's a great way to understand that a little bit better as far as why the patient can't breathe with these big dilated airways.
Correct. And, it brings up a really important factor too, is that a lot of people will get labeled with asthma, for example. And, bronchiectasis still kind of falls under that umbrella of reactive airway disease. And then that's really, really important to determine, do they have asthma or do they actually have bronchiectasis? Because we treat them very differently.
Now, how about the exacerbations? What kind of um, education or treatments, do you provide to the patient about these exacerbations and the impacts that they have?
So we actually have a dot phrase that we include in our documentation to reinforce the education we're providing to patients so that other providers see it as well. And it really essentially says if you have an increase in your clinical symptoms, increased cough, sputum production, any clinical changes within 48-hour period of time, we recommend a respiratory culture is obtained and that you are assessed by a provider to see if you need treatment. Because exacerbations can lead to loss of lung function over time. And that is what we're trying to prevent, right? And I don't like for people to just, go into an urgent care, somebody treats their symptoms, but doesn't really investigate that. And it's even becoming more and more important as we're looking at this patient long term because these people are experiencing this bronchiectasis probably for 10, 20 years. It's not just a one and done thing. We also, what might be a great resource for providers is that we start tracking these exacerbations. And a lot of times patients will say, well, how bad am I? Well, I was like, I can answer that question for you. And we use this bronchiectasis severity index. And this is a tool or a calculator that helps patients identify their risk for exacerbations, their hospital admissions, and their possible increased mortality as a result of it. We have a diagram of a snapshot of that calculator, and you actually just click on the drop downs and you individualize it to your patient and it creates a score, and then there's a key on the bottom that tells you where they're at on that severity index. And I think that's really helpful because then the patient starts thinking about that.
Mhm.
Every encounter that I have with a patient that I know has bronchiectasis, I would ask them, in 6 months, how many exacerbations have you had? Did you require antibiotics? Was it a virus that caused the exacerbation? Or was it an actual documented thing like Pseudomonas? And we do know that Pseudomonas has a higher frequency of causing recurrent infections and can be problematic for that ongoing chronic loss of lung function.
Now, you treat MAC, you see primarily MAC patients and bronchiectasis patients, and I feel like those 2 tend to go hand in hand as well, do they?
Yeah, they do because, one of our providers says, you can't have mycobacterial infection unless you have bronchiectasis, meaning you have to have abnormal infrastructure for it to be able to set up shop. And we used to sort of say that bronchiectasis was a chicken and an egg phenomenon. We didn't know what happened first. Was the bronchiectasis there and it allowed bacterial infections, including mycobacterial infections and others, to infiltrate in there? Or did the infection get in there and create the bronchiectasis? We suspect the latter, that that infrastructure was there, it was abnormal, and, it really just took that tincture of time for the patient to present with symptoms and then get that advanced imaging because nobody's just going to get a CAT scan to get a CAT scan.
Mhm.
So we won't be able to prove that. It's not like you go see your primary care physician and every year you have your physical and you get a CAT scan and we could say, oh, right there. It's one of those things that, we look at it at that time when things are changing for the patient.
Alright, well, let's move into management. We've identified they have bronchiectasis, they came to us coughing, they've been coughing forever, they've got some mucus issues, they've got breathlessness, we did some imaging, we found bronchiectasis, so now what?
So I'm a little biased, and the literature does not really endorse or show the role of airway clearance. It's just hard to do those studies, I guess I would say. But subjectively, and what we see with our patients is that airway clearance is truly the foundation of the care for the patients. If they're able to start clearing their airways, the patient will feel better. Their exacerbations risk may go down as well. So I really can't stress enough that that's the foundation of care. But you also want to treat underlying causes, which is the reason why we spoke towards the doing that full bronchiectasis evaluation. And you want to manage those exacerbations because we do know that those recurrent infections or exacerbations can lead to or reduced lung function over time. Some of the different types of airway clearance that can be utilized. I mean, I start at the baseline with a oscillating positive expiratory pressure device or OPAPP device. Some examples of that are an aerobica or an a cappella valve. These are flutter valves that kind of rattle a cage, so to speak. Mucolytics like hypertonic saline, there are different percentages. Sometimes patients don't tolerate different percentages, and we drop down. Kind of the universal standard of care is 7%, and we inherited that from cystic fibrosis. So we usually start with 7%. They do it through their aerobica device twice a day, followed by huff coughing. Um, to help mobilize those secretions. And I always kind of talk to patients about it and say, I liken your airway clearance to like flossing your teeth or changing the oil in your car, whatever analogy you want to use. But, my dentist says if I floss my teeth, I'm going to have healthier gums. But the reality is I don't go home at night, floss my teeth and look in the mirror and say, oh yeah, he's right. I have to trust the process. And a lot of our patients fall off the bandwagon because they put in the work and they didn't see a result. But bronchiectasis doesn't work like that. You could do your airway clearance in the morning, and then as that saline infiltrates and breaks up the sputum, or depending on the location of your disease, if it's lower lobe, it's going to take a lot longer to mobilize. And that could happen in the afternoon. And bronchiectasis inflammation can shift. And so, it kind of waxes and wanes where they might have a clear week until they're not clear. And so the airway clearance, you embrace that process and you do it. Um, and our patients actually do feel better, or they endorse feeling better. And, some of our patients are in latter stages of life where they're traveling and they take their airway clearance with them because they know that they're going to enjoy their trip. They're going to not have an exacerbation, and it's worth it to them because
Mhm.
they'll enjoy their vacation or what have you. We can escalate to high frequency chest wall auscultation, which are these vest devices or garments with a compressor. I usually see that one with Pseudomonas because it is a sticky, tacky germ and it's hard to mobilize. If you have a patient that actually has decreased lung function, we know that they don't have the musculature or the ability or the lung function to actually use a OPEP device like an aerobica. And so we need to take the work away from the patient and do it for them. And the vest can actually do that. One newer agent that's out there is the oscillation and lung expansion device. And I kind of reserved this for your COPD patients. They really, really like this. It's really effective for them. I don't engage this with all of my patients. I would do the vest first before I would go to the Valera device.
Okay. So Valera is the oscillation and lung expansion device.
Yes,
Okay. All right. I mean, another name for this is also pulmonary hygiene, right? We called it a lot of things over the years: pulmonary toilet, pulmonary hygiene.
correct.
I think sometimes when I use the hygiene word, and tell them this is to help clean or keep your lungs clean, it's pretty easy to convince patients when they've had repeat exacerbations because they want to stop that from happening. But the patients who haven't had any exacerbations, they just got a little mucus and cough every day and they've just lived with it. I think those are, for my experience, those are the patients that are difficult to convince them that we should get on some airway clearance of some sort.
And I know I work in an environment where I'm very fortunate to have respiratory therapists to go through the technique of airway clearance. I do not find that I have to convince a patient to do airway clearance. I am working in a referral center, so we're seeing people with more advanced stages of disease, but they feel better, and that's validation for them to continue doing their airway clearance. I think you might have more of a struggle in that healthy person that's not really symptomatic.
Yeah, definitely. All right. So, what are some long-term treatments outside of pulmonary hygiene? What else might you consider for these patients?
Well, with the recurrent infections where you isolate like a gram-negative, like a Pseudomonas or Klebsiella or Acinetobacter, some of these organisms, we sometimes use inhaled antibiotics to chronically suppress or manage that bacteria. And it's usually cycled because if we gave it to a patient every single day, then the body says, I've seen this before, and then it becomes resistant. So it's usually 1 month on, 1 month off, depending on it. And sometimes we cycle 2 different antibiotics inhaled, 2 weeks on, 2 weeks off, depending on if they're having breakthrough symptoms. During acute periods of time, we may give them an oral antibiotic based off of susceptibilities, or we may even go to intravenous antibiotics if we need to. Sometimes it's based on the bacterial load and how symptomatic the patient is, to determine how you escalate that. One exciting thing on the horizon now, which is why bronchiectasis is getting a lot of attention, is these DPP1 inhibitors that help manage the inflammation that's caused by neutrophils, which causes bronchiectasis and also leads to that exacerbations and recurrent infections. So determining if your patient is appropriate for that. Right now, the criteria is 2 exacerbations in a year. But you have a tendency to know who you're seeing pretty regularly, and that may depict that, yeah, they are a good candidate for this.
Yeah, if you know your patient is colonized with Pseudomonas and they're having 2 exacerbations a year or more, and let's say they're on rotating nebulized antibiotics, but you feel like they're having still exacerbations and breakthroughs, would they still be a candidate for a DPPI,
Yes,
even though you know what the underlying organism is?
yes.
Okay.
And the hope would be is that you break the cycle of those recurrent bacterial infections and that they don't need antibiotics. So that's the exciting part of it. Especially Pseudomonas is so hard because I've had patients, they submit a sputum sample and they're growing 3 different strains of Pseudomonas. And now I have to line up their susceptibilities to see if there's an agent that's going to hit all of them, for example. And they've been on this carousel of receiving antibiotics for their Pseudomonas for years. And, it's kind of exciting that there may be a future where we break that cycle and maybe they don't need those antibiotics.
Mhm. Is there anybody who's having frequent exacerbations who would not be a good candidate for a DPPI
Oh, I
inhibitor?
think we're still learning. I mean, so, during the clinical trials, there were exclusions to that clinical trial, and that was mycobacterial patients, cystic fibrosis patients, to name a few. So I think as the label gets expanded and we have a little more experience with the medication, we may see other applications for it for sure.
Okay. Very exciting. All right. So, what is the overall prognosis for these patients? They've been diagnosed. Maybe we've gotten on pulmonary hygiene. We've gotten their exacerbations under control. What does that then look like for them long term?
Well, we have to acknowledge the fact that bronchiectasis is a progressive disease. And so I think really with appropriate management of our patients that have bronchiectasis, they can really maintain a functional, independent lifestyle and have a pretty good quality of life. I kind of, sometimes patients get overwhelmed by that. I have this thing that's never gonna go away because once that damage is there, it's always gonna be there. If we intervene early, then maybe that damage is not so severe. And the other thing is I liken bronchiectasis like managing a chronic disease process like high blood pressure or diabetes. Like we can't forget about it. And there are things that are going to add to this patient's day. But, the end result is less antibiotics potentially and a better quality of life.
Excellent. All right. Well, if you were to wrap it up for everybody, what would you say the biggest takeaways are for these patients?
Yeah, I mean, just as I said before, bronchiectasis is a complex, chronic condition, um, requiring individualized and very multidisciplinary care. um, some provider resources that may be helpful to help your patient navigate this. There are designated referral centers for NTM and bronchiectasis, and they are called clinical care networks. It is these clinical care networks. They're mimicking cystic fibrosis centers in what is required to be able to be designated as a clinical care network. But I think what it will do is it will provide resources for patients all across the country instead of requiring them to go to specialized centers of excellence.
Those are good resources for patients, but how about resources for our providers? Are there any out there?
Yeah, I mean, there certainly are. So, I mean, most of referral centers, if you have a very difficult case, they're willing to help you navigate that and help you answer some clinical questions. But the biggest resources is the chest bronchiectasis guidelines. They've been presented at the chest conference and subsequent conferences since. They are currently under the publication is actually pending. The other thing is the European Respiratory Society has guidelines for adult bronchiectasis patients. And so we will provide that link for you as well. And just look for those chest bronchiectasis guidelines. They should be coming with the new year relatively soon.
Yeah, we're currently recording this in January, so hopefully by the time this episode comes out, those guidelines are out, and they are a great resource for everyone to look at as far as like management and diagnosis and diagnostics and things that they recommend. The last broadcast outcome or guidelines they put out, I thought were very helpful, especially if you're even if you've been seeing bronchiectasis forever or you're newer to it. It's a great resource.
I agree.
Yeah. All right. Well, Jennifer, thank you so much for joining us again. Great to see you again, and so happy that you're able to share your knowledge with our listeners. So thank you again for joining us.
No, thank you for having me.
Absolutely. Don't forget to claim your CME for listening to this episode of the APAP podcast. The link is in the show notes. You can also find it on our website. Don't forget to like and subscribe and share and all the things to help continue to bring you this free CME educational content. And we will see you guys on the next podcast.